Thank you all for joining our monthly Dunlevie lecture series. A couple of Dunlevie Center updates. The spring 2024 seed grants, our applications are open. They open on the 12th. We'll close on April the 15th. The center funds 2 awards, $35,000 each for 12 months starting July 2024 for this round. And for more information, just visit our website. Next slide. Our next speaker for March 14th is Dr. Nicola Sananis. He's professor of OBGYN and MFM at the American Hospital of Paris, France. And he'll be talking about innovations around fetal endoscopic tracheal occlusion. But it is my pleasure to hand the reins over to Dr. Blumenfeld, who will introduce our speaker today, Dr. Avi Tsur.
Thanks, Yasser. And I know that our speaker today doesn't really need a lot of introduction because of he's obviously been here, spent over 2 years here, and collaborated with many of the individuals on this call. But I thought I'd have a little bit of fun with this presentation. People always say it's my pleasure and honor, but besides the pleasure and honor part, it's really fun for me to have Avi back in this capacity. And the first part I was happy to see is Avi learned a lot while he was here, including how to make a really bombastic title and to include a lot of affiliations after his name. So mission accomplished in terms of the additional training that he received here at Stanford. What he didn't include, of course, is his clinical affiliation, academic affiliation with Tel Aviv University, but clearly he's, after spending time here, he went back to Israel and did a lot of amazing things that he'll tell us about. But I thought about saying, when did I meet Avi? And I looked through my email and I found this email about the March of Dimes, new paradigm for prevention of preterm birth. And I wanted to just highlight the fact that this is November 2nd, 2015. So it's been now almost 9 years, 8.5 years since we first heard of somebody by the name of Avi Tsur. And it's really, I want to thank David for bringing Avi and getting that initial connection, getting him within the Stanford ecosystem, and then having the rest of us sort of benefit from him being here. And I think it was a very nice symbiotic relationship. So Avi was here from 2016 to 2019. And he went back to Israel to a hospital named Sheba. And for those of you not familiar with Israeli geography, I honed in on the center. You see Tel Aviv on the left by the beach, and Sheba is one of the premier hospitals within Israel, one of the largest. Just to give people an idea, 10 to 12,000 deliveries for those of you who do obstetrical care, to give you a sense of the volume. So he went back there and lives near that area. And what he really started doing, is he helped develop this center at Sheba called the ARC Center for Innovation and Digital Health. And today he leads the women's health division, not just the obstetrics and the fetal part, but really all of women's health within this innovation center in his local hospital, in addition to all the clinical care and other things that he's doing. And really the hospital took on a huge innovation program with a lot of resources to become a leading institution, both within Israel and beyond. And so looking at what he's done since going back, you can see the date 2020. This is the first thing from the ARC program, looking at telemedicine for women's health. This is 3 years ago, 4 years ago now. Then in 2021, building on that telehealth, you can see a lot of remote ultrasound monitoring, not just telemedicine, but ultrasound. This is 3 years ago in the height of the COVID epidemic. Obviously, a lot of incentive to do that and leveraging the resources there. And then, of course, with the new buzzword called AI and machine learning and all these kinds of things, you can see from 2 years ago, now using a lot of AI paradigms for clinical care that I'm sure Avi will tell us about. This is the website for OpenAI. Unless you've been living under a rock in Silicon Valley, you now know that there are several companies in the artificial intelligence space. The most prominent has been OpenAI with ChatGPT, and we can spend 3 hours talking about them. They're obviously under Microsoft now, but this is their website for those of you who have never actually gone onto the OpenAI website. And just to give you an idea how much AI informatics has come along into our care paradigms, even Stanford Medicine a week or two ago came up with their own GPT service for the hospital. And for those of you who didn't get the email or didn't log in, this is actually what it looks like. So you can go in and it looks like a ChatGPT thing. And you say, okay, what can I use this for? And I just took an example, and just to show you, I typed in, please draft a letter for an employer for a pregnant patient, excusing her from work due to a physician visit, something we do all the time. And the program drafted an entire letter that you can essentially cut and paste into your own thing. So this is just one of the very mundane things that we and people are starting to use. Even Stanford GPT, you can see in the beta version in our daily life. So this is rapidly entering all our lives. But I thought about, the time that Avi was here and looking at, okay, when did all of this start? And so when you look at PubMed, I PubMed machine learning and pregnancy, and even within machine learning, you can see I highlighted 2018, 60 manuscripts out of the 1,300 that we're seeing now. And even among the 60, 99 were not even with machine learning or artificial intelligence. But to give you an idea of A, how rapidly this is developing, and B, how much at the forefront Avi was at the time when he really was thinking about these issues and developing it. And just one quick anecdote before I let him present. This is a manuscript you can see was published in 2020 in the White Journal. And towards the end of Avi's time here, he said, listen, I'm collaborating with UCSF and the data, and I have a couple of these AI engineers in Israel. They're really good. Can you join and help out a little bit? And I say, sure, I know what I know about machine learning. So I joined the group and draft this manuscript, and it gets submitted to the White Journal. And just to give you an anecdote about how the distance that everybody's traveled since 2020, the manuscript gets submitted, it gets reviewed by like 2 statisticians that have no idea about machine learning, and they give comments that are not quite germane. Avi responds beautifully, it gets sent. And about 2 weeks later, I get a call from the editor of the White Journal that knows me, and he says, look, I see this manuscript, it looks great on paper, I have no idea about this machine learning, I just need you to tell me that the scientists behind this work, that it's scientifically valid. I don't have the editors to tell me if it's good or not. It looks good on paper. Just tell me, can I publish this without publishing fraud? And I said, listen, yeah, this is like cutting edge stuff. It's really good. Please, it's a good paper, and it gets published. So just to give you an idea that in 2020, not too long ago, they didn't even have the appropriate editors to analyze the way machine learning is being presented and how far we have come. So this is Avi and I 3 days ago, come full circle. This is in beautiful Baltimore. I don't know, somehow there are beautiful places like this in Baltimore. And it was great to catch up with Avi and learn about everything that he's done. So I will end here, Avi. The floor is yours. It's really a lot of fun, and looking forward to hearing where the next 4 years will take us and where the phone calls from the White Journal editors will come next, asking us, is it scientifically valid or not? So I will stop here.
So it's really a great pleasure to be here today. I'm really excited. I gave a similar presentation a few places in the last few weeks, but returning to meet my mentors and friends from Stanford is really very exciting for me. And that let me open the slides. Do you see them?
Yes, looks good, Avi.
And really, before I start, I must say that the 3 years at Stanford, starting at David's lab and the March of Dimes, and the clinical time with the MFMs and the clinical investigation, was really, it's hard to say how significant it was for my development. And also the 3 years were for our family very significant. We came to Stanford with 3 children. We went back with 4, and now we have our 5th. And I hope that following today's presentation, we can find new opportunities for collaboration. And I have some financial disclosures, thanks God, but any of them are not related to the stuff I'm going to be talking about today. And you know, I have this learning objective slide, but really I want to share with you the work we're doing with transforming the pregnancy journey home, to talk about its benefits, its potential risks, and how we mitigate them. What are the human, technological, clinical, and logistic factors we've been addressing to make things happen, and then to talk about the potential use of machine learning and precision medicine to optimize stratification of women for home care versus traditional inpatient admission. So, you know, our Women's Health Innovation Center, like I think any innovation center, any clinical innovation center should be, it's always about the patients and always about providing better care. And here you can see me during one of our first COVID-19 C-sections. I used to be, I wasn't afraid of the COVID-19 C-sections until I got myocarditis myself following COVID-19. So I did a lot of them. And, you know, while we were wearing all this gear to protect ourselves, we had women coming to the clinics, you know, kind of moving from place to place, not to sit too close. And we were thinking, what can we do in order to treat them remotely? So at the same time that Sheba, our internal medicine, pediatrics, many disciplines were transferring care home. And clearly it was, we understood what the challenge was with pregnancy, having more than one patient, having two patients, one of them within the other patients, and the challenge of treating and following the fetus at home. And we decided, so I read a few times Maury Drusin's chapter about antenatal testing, and Maury clearly states that the modified biophysical score based on this study from 1990 of David Miller has the same false negative for intrauterine fetal death, similar to the modified biophysical, similar to the full biophysical or the contraction stress test, and which is also much better, fourfold better false negative compared to NST alone. And that's why we decided to integrate the fetal monitoring with the remote fetal monitoring with remote ultrasound for maximal vertical pocket, and do it together with all the other aspects of remote care that already are out there, the ongoing glycemic control, the video encounter, the digital urinalysis, vital signs, and really create comprehensive remote care visits. And we used mainly Israeli technologies for various reasons. This is one company, Heramed, a great company. However, the fetal monitoring does not include data about the contractions. At the time, it didn't seem important to us. However, eventually, so you see, if you see a 32-week GDM patient, you don't care too much about the contractions. However, if you get fetal decelerations and you don't have the contractions, it's sometimes hard to interpret them without context. And therefore, we moved to using Nuvo's technology that integrates fetal monitoring with uterine contractions. The technology is also interesting because it's actually based on fetal ECG. So they present it as NST, but actually it's based on ECG, and that's why there's more interesting data hidden there. We use the Healthy.io digital urine dipstick, and this is the ultrasound we use. Another Israeli company, Pulse-Ro, that provides 3-channel ultrasound, so the patient can see us, we can see the patient. You can see here with a dog, and of course we can see the fetus. In the beginning, we used it, as I said, only for modified biophysical profiling, just for the maximal vertical pocket. Eventually, we discovered that we can do the full biophysical for all patients. So currently, we are doing full biophysical together with NST. And we developed our own app, providing ongoing glycemic control and ongoing blood pressure measurements. And we started with a feasibility pilot study, really very basic. We provided 10 women with a room. We trained them, then they came back to, so Yasser, I apologize, but the ARRIVE study didn't have too much a transformative effect in Israel. We continue following women post-date after 40 weeks. So we have to know, I assume if someone from Stanford would come, would be kind of amazed to see women after 40 weeks still moving around and coming every 2 to 3 days for surveillance. But they were a perfect population for investigating the use of remote care. And so we trained them 40 plus, for exactly 40 weeks of gestation. Then when they returned a day or two later, we just wanted to examine that they are able to connect to the fetal monitoring by themselves, that they're able to connect to the ultrasound by themselves. We also looked into the time saving and satisfaction, but it was less important because it's really very low numbers. It's only feasibility study. But we also asked an open question. We asked them beyond, some validated satisfaction questionnaire. We asked them an open question, which was, what is the most important part of remote care in your mind? And the favorite aspect that most of them picked was the increased control and direct assessment of their fetus. So that's something we were not anticipating, and that's something that was really important later on in engaging women to this service. And the way we do, by the way, it's interesting to the way we do. So a lot of our research, we have our residents as first authors. So here you can see Omer Nir is one of our brilliant residents. This is our department chair, Professor Eyal Sivan, both coming on Friday as part of this study to see patients remotely. And the next step was the real thing. We took women with gestational diabetes, and I think to the best as I remember, Stanford also, women with A2 GDM, women come at least once weekly, some come even twice weekly for NSTs. And what we did was to take women from 32 weeks. We took 20 women and we compared 2 clinical visits in hospital with 2 remote visits. And again, I'm talking about comprehensive visits that replace the inpatient visit. So we do everything. We talk with the patient, we do the NST, we do the modified biophysical, we do a digital urine dipstick, we take vital signs, and the MFM obstetrician concludes the visit. So we had 20 participants here between 31 and 34 gestational weeks. One participant withdrew consent after the first virtual visit. It's interesting. So the hybrid care, although women, they don't need to have a lot of knowledge, but they do have some effort. So it's not like when you come to the clinic and you just sit in the sofa and someone connects you. You need to connect yourself. You need to be on time. And we noticed that the numbers of the study are right also when it became as a service. Around 1 in 20 prefer to be more passive. And from our point of view, it's kind of an exclusion criteria for joining the service. So one patient withdrew consent after the first virtual visits. So we had 39 remote visits. Of them, 38, we were able to conclude all parts of the remote investigation. For one patient, BMI 40 at 32 weeks of gestation, we were not able to complete the remote monitoring for technical reasons. So we had to bring him to the clinic, and she did the NST in the clinic, and it was fine. Then for the same patients, 2 weeks later, the same BMI, but the fetus a bit bigger, we were able to do the remote visit, including the NST. So what we learned from it is that it's okay, women 32 weeks, it's okay, BMI 40, but we don't do both. So if women of BMI 40, we start remote care only from 33 weeks. And the time saving was amazing. And I think, by the way, the time saving we had at Israel, at Sheba, would be even more dramatic at Stanford. Okay, because the travel, our problem is less the distance, it's the traffic and the parking. So it was 60 minutes for the remote visits compared to 3 hours for the inpatient visit, which was associated with very high patient satisfaction. We used the telemedicine usability questionnaire, and no adverse events occurred. And based on it, on this step, we opened the real service, and you know, thinking of potential collaborations. This is the poster. I took the picture. I'm sorry, it's not very high quality, from Oregon. Clearly, the remote visit, the NST and modified biophysical visits are a nuisance for patients. For some patients, they have negative psychosocial impacts. For some patients, it's more than that. They create a real financial burden, missing work, not being able to provide childcare. I think that not only in our setup, the ambulatory care, the remote ambulatory care may be exciting. And then when we wanted to open a service, so the clinical pilot part was really fun. The greater challenge was making it from research and a pilot to a real service. And we have at Sheba Beyond, that's our remote hospital. And you see here Galia, the hospital director, and the deputy Adar. And what were the challenges? One was the human challenge. We created new roles. So you can see here Esti. Esti is the head midwife of our remote service. She's a regular midwife. And I remind you that in Israel, most of the deliveries are done by midwives. Only when we need operative vaginal delivery, we intervene. So Esti does both regular midwifery, but she's also head of the remote care service. And similar to her, we have an ultrasound tech that's head of the remote care ultrasound tech service. And, you know, they provide a full new realm of knowledge of following pregnant women at home. Another great challenge we had, and I think this challenge will be even bigger in the American setup, was the reimbursement. So the thing is, changing the pregnancy journey, it doesn't, we're not expecting it too much, although we did present this SMFM, some data about how it improves patient compliance and how it could improve glycemic control. In general, however, we don't expect it to lead to very big improvement in clinical outcomes. The improvement is in patient satisfaction and patient journey. And there's not enough of an incentive for the payers, or in our system for the HMOs, to do anything to promote it. And it took us time took us a year from publishing the pilot to getting our first agreement with the largest HMO working with us to provide reimbursement, but we did it. And now we have a very good bundle for remote MFM care. And the other challenge is technology. So I showed you the technologies we're currently using Nuvo and Pulse and More for remote fetal monitoring and remote ultrasound. But we have two additional challenges. One is all the time thinking of new technologies. Currently, we are going to be integrating Lumify, so we can do ultrasound with Dopplers for some indications at home. I'll share with you these indications. We're also looking into continuous blood pressure measurement for women with preeclampsia that are in the antepartum admission. So we prefer continuous blood pressure measurements at home, and I'll talk to you about it as well. And the greatest challenge with adopting new technologies, and I assume it will be the same in Stanford, is not only selecting the right technologies, but is having them integrated into the system, into the EHR, going through the firewall. It's a great challenge. I'm not going to go into it, but I must say that a lot of our time goes into overcoming hurdles related to integration of the technologies. I tell you one challenge we don't have, that's space. So everything you want to do new in the hospital, you need new space, you need new building, you need new funding. We don't need space. The patients are at home. Here you can see one of them next to the seaside. So the space is actually a great thing. We are not only we don't need space, but actually we are creating new space that is not used because the patients are at home. And before I move to the antepartum admission, I must say that treating patients remotely also opened us really exciting opportunities. One of them was together with our colleagues in Hebron, that's in the West Bank. We've been treating Palestinian women with GDM and chronic hypertension. And it's really a very different setup. So we trained a team of 10 OBGYNs, midwives, and community health workers. And we created a similar service moving between the villages in Hebron area. And one of our residents, which is now an attending, Hadil, joins them once every 2 weeks for kind of visits on the complex patients that they don't know how to adjust the diabetes or the treatment of chronic hypertension. And actually, this was really one of the most exciting things that came from the remote care. That was the ability to leverage medicine to connect between people. And as we were excited of the remote ambulatory care, we were thinking, how can we really extend it towards the most important part of the hospital is not the ambulatory care, it's actually the admission. It's those women with more complicated conditions that are admitted to the antepartum department. And so clinically, there was not much of a difference. And technologically, there was not much of a difference. But the challenge was, again, regulation and reimbursement. And then similarly to what happened with COVID-19 that opened the way for the ambulatory service, October 7th, Israel in general, but also specifically our hospitals were under a brutal attack of Hamas with missiles launched. And here you can see one of our hospitals hit by a missile. And there was a decision to send patients home. So we have 39 antepartum admission beds, and the decision was we can keep only 15 of the beds. And this created the, like they say, the 2 letters for crisis in Chinese are danger plus inflection point. So actually, this crisis created an opportunity to start opening the remote service for antepartum admission. And we called it intense remote care, because not as the ambulatory care where we see the women for a comprehensive visit. With the intense remote care, we talk about seeing patients 2 to 3 times a day, with fetal monitoring 2 to 3 times a day, with daily ultrasounds, with 2 to 3 times a day vital signs. And as we developed the service, we looked into a very interesting study coming from the Netherlands. In general, we look a lot about what's happening in the Netherlands. Our Dutch colleagues have really interesting value-based care. And here you can see in the hotel study, what they did is they compared 100 pregnant women with indications similar to what we do for antepartum admission: preeclampsia, fetal growth restriction, preterm rupture of membranes, recurrent decreased fetal movements, fetal anomalies, and bad obstetric history. I think that most of these indications are also Stanford indications for admitting women. Perhaps fetal growth restriction, we have more of them admitted in Israel and in Europe. But anyway, these were the indications, and they compared 100 women with home care compared with 100 women with traditional antepartum admission. And the only thing I did not agree with the study is the primary outcome they selected. They decided to use, for statistical reasons, a composite outcome that integrated not only things that are related to home care, but actually also cesarean section during labor, which is, in my opinion, I assume you would agree, is less related to home care versus traditional admission. And based on the primary outcome they defined, the numbers were similar. So the number of the primary outcome was 31 versus 40, which was not significant. And therefore, they concluded that there is no clinical difference between antepartum admission at home to traditional antepartum admission. However, when we look into the numbers, you can see that among the 100 women at home, there was 1 case of fetal mortality, and there was 1 case of eclampsia at home. And because we really want this service to be something that will be ongoing and we'll be able to treat most of our patients at home, we decided we want to modify the Dutch protocol so we are able to really have larger safety margins, so we can succeed with this and move home. Because at least in Israel, if we would have one case of 100 with IOFD and one case with eclampsia at home, the Ministry of Health would stop this program. So we took, I'm comparing our protocol to the Netherlands protocol. So training of the patients was face-to-face. Treatment plan was individual. It means, what does it mean, individual treatment plan? You decide the number of NSTs and the number of blood pressure measurements and the timing of blood work, etc., based on the indication. We also did similar to them, we do real-time NST assessment, which means we have a 24/7 midwives team that see the NSTs taking place at home. However, what we changed compared to the Netherlands protocol was, instead of doing the NST once daily, we do it for women with fetal growth restriction and preeclampsia twice daily, and for women with intrahepatic cholestasis of pregnancy 3 times a day. Another thing we did was adding the modified biophysical, not only NST, but also the maximal vertical pocket, that, as we observed earlier, dramatically decreases the rate of false negative reassuring fetal monitoring. And the other thing we did is, not only, so the Netherlands study, they did blood work once weekly, we do it twice weekly. And the cool thing we do is, and I don't know, are you currently using at Stanford the SFLT1 PLGF ratio?
No, it is not a part of standard.
Not that. So, some centers in Europe started using it. And actually, people asked about the SMFM. So I like this, there was a presentation of the PRECISE study. I think the SFLT1 PLGF, so I'll just say a few words about it for those less familiar with it. The PLGF is being used in Europe for prediction of preeclampsia. But however, in this context, it's being used, the SFLT1, which is anti-angiogenic, and PLGF, which is pro-angiogenic. So the ratio is being used to detect women that have increased risk of developing severity features, preeclampsia severity features, within 2 weeks. So we use this ratio, and all our women at home with preeclampsia have a ratio of below 40, which is associated with low risk of developing preeclampsia severity features within 2 weeks. And another difference of what we do compared to the Netherlands protocol is the hybrid concept. So our patients are both, although our patients are at home most of the time, they come to the hospital twice weekly, and not only for blood work, but we actually ourselves, the same team treating them remotely, treats them when they come to the hospital. So they have continuity of care. They have the bed kept in the hospital. So if a patient has deceleration, etc., we bring them in easily. I'll tell you, how much time do I have left, by the way? Until when do we have?
5 minutes, ideally.
Okay, so I won't go too much into the criteria. I'll just say we have non-eligibility criteria that are meant for high safety. And I'll share with you our data. So currently we had 30, we started it October 8th, since we had 30 women admitted to the antepartum, remote antepartum admission, women with fetal growth restriction, preeclampsia, intrahepatic cholestasis of pregnancy, bad obstetric history, and pyelonephritis. We had 3 ultra-Orthodox women among these 30 patients that did not use, prior to this, to enrolling to the service, they did not use smartphones, but they were able to learn it, and the day after use all technologies. We had up to 7 patients concurrently at home. The average number of days per patient is 12. 23 of them delivered with high satisfaction in Sheba. The other 7 are still ongoing. We had 1 case of full conversion for technical reasons, of unstable eye and we couldn't do the anesthesia at home. We had four patients that during their intense remote care, we identified signs that they had to move back to the hospital. We call it to convert back to the hospital. One of them had a fetal growth restriction and developed abscess in the umbilical artery. Another had preeclampsia and had severe blood pressure measurements. So from our point of view, being able to catch these women on time and bring them back to the hospital, in some cases deliver them, is exactly what this protocol is tailored for. We had 6 patients that improved, mainly patients with fetal growth restriction that had improvement in fetal percentile, in estimated fetal weight percentiles, and moved from admission to twice weekly assessment in the ambulatory service. And we had 1 case of failed recruitment for technical reasons. So far, we didn't have any adverse events, and that's our focus. And I'll use the few minutes left to talk about, the potential collaboration avenues regarding this service. So, just to mention again the use of sFlt1 PLGF, this ratio provides a statistically significant certification of the risk of progressing to severity features within 2 weeks. And only 4% of the women with a ratio below 40 do develop severity features within 2 weeks. So some people in the SMFM, when I presented it, asked me, couldn't these women be at home? I mean, women with preeclampsia, with a low sFlt1 PLGF ratio. And my answer is they cannot be at home. They need to be in the hospital. And their answer, and the reason for that is clear, is because they have, 4% of developing severity features. And among this 4% with high risk for developing severity features, 1 in 50 will develop eclampsia at home. That's exactly the case of Tori Bowie and other cases of preeclampsia that have eclampsia at home that we want to prevent. And I think that leveraging the remote service is a great economical and clinical and patient-centered way of preventing these complications at home. And I tell you where's the place that could be really interesting for collaboration between our centers. So what we are looking into, and I think most of you are aware of Michael Snyder and his colleagues' work about wearables and the medical revolution. This is back from 2016. So, there are endless number of potential wearables. We're looking into 3. One is continuous glucose monitoring. The other is continuous blood pressure measurements. And the other is perhaps the coolest technology is continuous fetal monitoring. These are the 3 continuous technologies we are looking into for our women at home. And what we're trying to develop is a digital twin of our home patient that is based. So I think in this people, most of you are aware of digital twins, but I just say in a word, a digital twin is you have a real world entity. It could be an airplane, or it could be a patient with preeclampsia. This entity has a virtual representation of based on machine learning models, and there's data that connects the 2 dynamically. So we're able to assess. It's not like when we predict preeclampsia at the beginning of pregnancy, we say there's low risk or high risk. We want to be able to say for each of our patients, dynamic assessment. So she could be low risk at home for a week or 2, and then based on continuous measurements, we see an increase in her risk, and then she stops being low risk and needs to convert back to a traditional antepartum admission. So this is a different way of representing this continuous model. I was hoping to have already preliminary data to show you. We are seeing nice results, but it's still early to share our analysis here. I do think this could be a very cool place to collaborate about, especially comparing data between different different populations, etc. Especially because of the wide experience of many of you in leveraging deep learning tools. So these are kind of just to outline the two things I've been thinking that could be potential for future collaboration in the specific realm of remote care. One is we're thinking now of a joint study with Karolinska in Sweden, which is also a very patient-centered care center. And it could be interesting to think of a 3 national clinical investigation of remote care. That's one potential collaboration option. And the other is collaborating on data in development of the digital twin. I'll finish my presentation by telling you, when I went to the SMFM, my kids asked me, so our patients at home, I see them myself on Fridays and Saturdays, and on Saturdays I do it from home. So the patients are home and I'm at home, and my kids, I go to the room, close the door. So from their point of view, that's how medicine is. Patients are at home. And when I told them I'm going to talk about it, they said, Dad, what's so special about it? They were surprised that there's an alternative option. So at least my kids are persuaded that remote care can work. And hopefully we could find ways to work on it together. So thank you. Thank you very much.
All right, thank you so much, Avi. I know we don't have a ton of time for questions, but I'm glad you left your email and people can follow up with you. Do you mind unsharing? And then if somebody has a question, they want to put it in the chat. We see one from Ron who left, but if somebody has a quick question in the last 2 minutes that we have.
I just want to say that I really like the idea of the digital twin. It's a different way that you would assess the risk to what we would do, right, with prediction using machine learning. So really like this idea.
Avi, since we have neonatologists and OB anesthesiologists on the call, can you talk about sort of your partnership with neonatology and OB anesthesia at Sheba when you were thinking about these protocols? What did the other services think? Did they think you're crazy? Did they have any objections? And how? Talk about their input into these paradigms.
So I tell you, the main input of the neonatologist was regarding another aspect of the remote service. That's the early discharge of the early postpartum discharge. The greatest challenge there was that's for you, David, was the bilirubin assessment at home. But regarding the antepartum, the neonatologists, the only thing that they were concerned of, it will increase the number of our patients, and then they'll have a larger burden on their side, but nothing else.
Avi, really nice presentation. It's great to see how successful you've been, and you've followed along lines that we've talked about. I also like the notion of using a digital twin where you can actually experiment on the computational side to better predict what might be happening, where it really makes a difference. And we've been doing some work on that as well. We also have some additional, I think, unique signatures and approaches for prediction, which might be interesting to introduce into your system and help you in that regard. But I think you're doing a fantastic job. And I love the fact that you can use telemedicine to basically not only protect patients at home, but make decisions about when they should use other kinds of services. And I think that is a good thing. And I think also the fact that you're able now to extend your expertise into other communities, which I think is really important and again, a really good thing. So I congratulate you on what you've been able to accomplish. We're tracking you at a distance. We see your impact on the field. So we appreciate it very much.
Thank you.
Thanks. One last quick question about reimbursement. You said you were able to get the HMO to pay. Is it equal to inpatient care, or is it different? Were you able to get just close to it, but not quite the same?
So actually, so the greatest concern of the HMOs, which is our version of payers, was that we'll abuse. So once we get a remote care CPT code, we'll be doing more. So let's say we need to see a patient, just she calls because her glucose levels are uncontrolled. We'll bill them for a visit. So what we did was we developed a bundle. We said, how many visits do we need for a GDM patient? How many visits we need for a chronic hypertension patient, etc. And it's a bundle of the average number of visits. And what changes, they don't pay for the actual number of visits. They pay for a bundle of expected number of visits per patient, but they pay more than usual for this bundle. And actually they are kind of leveraging it to pull pregnant women from the other HMO they're competing with, and promising a better pregnancy journey.
Well, thank you so much. I know everybody needs to get to their clinical roles, and really appreciate you logging on like this. I know it's 11 o'clock where you are, which is pretty standard hours for you anyways, but have a wonderful evening, and thanks everyone for joining, and we'll see you next month with Dr. Sananis. Thanks, Avi. Good to see you.
Thank you very much. Good seeing everybody.